Thank you very much. Good afternoon, ladies and gentlemen. I'm first of all very honored to share with you, to be here with you and share with you some thoughts about oral health. And of course, in particular, how the Commission is addressing this issue in its various policies and initiatives. And some ideas we have about how we could further integrate oral health issues in future initiatives. Let's start by really maybe stating the obvious, but we all know that most oral health problems could be avoided or at least delayed by very simple precautionary measures, the regular cleaning of teeth, early treatment of caries, and so on. So therefore, the first immediate conclusion that I would draw would be that dentists and associated oral health professionals have a key role to play in providing advice on health promotion for patients, especially on important determinants of health and various risk factors. And we should not limit ourselves to the well-known and obvious correlation between sugar intake, for example, insufficient teeth brushing, and the development of caries. But we would like to see also a wider role and importance of oral health, for example, on other issues. Smoking, alcohol, for example, are also very, very relevant. I would like here to make a particular parenthesis. If we look at, for example, at the disturbing statistics about the health of young people in particular, where there's clearly a need for more health promotion, more active health promotion. We know that for professionals, dental health professionals are very often among the few, if not the only, health professionals that young people, for example, see on a regular basis, hopefully. And therefore, there is a tremendous importance there to promote oral health in the wide context of the general promotion of health. Now, the Commission is very well aware that all of this may require a mind shift in certain quarters, but we need to strengthen all the possible avenues we have to really put prevention at the forefront of medical care. This is absolutely essential. And we do this for a very, very good reason. Chronic disease is a massive problem in Europe. It's the main cause of death, the main cause of a poor quality of life. It's causing an increasingly high economic burden by attacking the most important thing for Europe. It's valuable human capital. The capacity of people to work in the prime of their lives. Just to give one example, every year in Europe, we lose almost 700,000 people every year prematurely just through smoking-related diseases. Just one example. Not to mention the growing obesity epidemic, and so on and so forth. The good thing is that the most common oral diseases are largely preventable. But of course, if they are not treated, they become chronic. And therefore, there is an intrinsic link between the oral health agenda and the chronic disease agenda, which is now really at the center of the Commission's efforts and that of the member states. Now, to be clear, our intention is not to develop a specific policy on oral health. We have already a multitude of policies. What we need to do is to make sure that all the policies we have are connected, are implemented, and that oral health is seen as an integral part of those policies, not as something extra or something additional. It is an integral and vital part. Let me just give some examples of the main EU policies which are very relevant and pertinent. First of all, as I already referred, our tobacco policy. We are witnessing, also because of certain marketing techniques used by the tobacco industry, an increase in the use of not just smoking, but also chewing tobacco and other novel forms of tobacco. And we all know is proven beyond any doubt that these are major risk factors in the development of cancer, including oral cancer and other oral diseases as well. And therefore, it is a primary objective, it should be a primary objective of all of us, to achieve a decrease in the prevalence of smoking and tobacco consumption. This would make definitely an immediate contribution to oral health in the EU. In particular, we need to take all possible measures to make tobacco less attractive, in particular to young people, and to ensure that people are fully informed and are fully aware of what tobacco in all its forms can do to their health. At the moment, in the Commission, we are looking at the regulatory means. This is an area where we do have regulatory tools at our disposal, and we are working on a proposal to strengthen health warnings on cigarette packs, to regulate flavors in tobacco products, and to revise the Tobacco Products Directive to bring it in line with various market, international, and scientific developments. The fundamental aim that the Commission is pursuing is to make tobacco products less attractive. In addition to that, of course, Member States should continue to enforce the legislation to ban tobacco smoking in public places, to develop awareness campaigns, and, very importantly, to support people who wish to stop smoking. Evidence shows that smokers suffer up to 6 times more from dental disease than non-smokers. And in this light, of course, I have confidence in your support to our actions in tobacco control policy. Let me move on to nutrition, another fundamental determinant. The Commission's work in this area is guided by the strategy on nutrition, overweight, and obesity-related health issues. And, of course, here we work closely with the Member States and with the stakeholders to implement the strategy. We have the high-level group for nutrition and physical activity, which shares ideas and best practice on how to improve the diet and to increase the physical activity levels of Europeans. And the EU platform for action on diet, physical activity, and health was created with a view to establishing a forum for action for European-level organizations ranging from the food industry to consumer protection NGOs. One area where we need to pay particular attention, also in the area of oral health, is in the increasingly marked differences depending on social groups. Poorer, less well-educated people have worse tooth decay and more damage to their teeth and gums. And there are a number of reasons for this. Higher than average levels of risk factors, such as sugars in the diet, poorer levels of personal oral care, worse access to dentistry, and generally low overall levels of health. There are also big differences between the Member States. The proportion of the adult population with all their natural teeth varies from a low of 19% in Hungary to a high of 57% in Malta, Cyprus, and Denmark. Whilst over 80% of adults in the Netherlands report seeing a dentist in the last year, the figure for Romania and Hungary is less than half of this value. So clearly, still a lot of work which needs to be done. Ultimately, of course, it is the Member States who are responsible for the provision of health and dental services. What the EU is doing is to work closely with the Member States to support them to address underlying economic and social factors which contribute to health inequalities. And the Commission would, again, encourage the Member States to make the full use of the possibilities offered by structural funds for this purpose. Another issue we have to pay very careful attention to in the context of oral health is the aging question. Our population, as we all know, is aging, and older adults have specific, and sometimes more, certainly, oral problems than the previous cohorts. Caries, periodontal disease, as well as oral mucosal diseases, pain, salivary dysfunction, impaired chewing, tasting, and swallowing, all with a very direct connection also not just to health, but also to the quality of life and the ability of these persons to live active lives, which is our ultimate objective. As people live longer and retain more natural teeth, it is no longer appropriate to connect geriatric dental care with denture care, because the complexity of older adults' oral health treatment has increased and now must also include complex restorative procedures, aesthetic dentistry and implants, as well as oral hygiene. Older people who live in residences and those with cognitive disorders have special needs as well to prevent tooth decay, gingivitis, ulcers, and in this respect, formal and informal care needs to be reassessed, and carers need to be aware and trained on how to provide oral hygiene for these individuals in these more complex situations. The European Innovation Partnership on Healthy and Active Aging has not put forward any concrete initiative in the area of oral health as such, but there is no doubt in our mind that oral hygiene and oral health is absolutely essential prerequisite for really healthy aging. Nevertheless, some oral health problems have links to some of the priorities which have been identified in the partnership, such as chronic disease, malnutrition, adherence to treatment, and cognitive impairment and health literacy. The Commission very much welcomes today's release of the State of Oral Health in Europe report, commissioned by the Platform for Better Oral Health in Europe, because it does establish very clear links to the above-mentioned policies, and it does provide very important figures and evidence for further development of these and general health policies. Let me conclude by expressing my hope that oral health should become and could become a really integral part of health promotion and well-being. And certainly the only way to achieve this is to ensure that we bring the oral health community closer to all the other public stakeholders. And I therefore very much welcome this meeting as a concrete step in this direction. Thank you.